and very welcome to this very hot topic, I think. Now we have lots of data, we need more data, but according to this study, we will see what the fact we have and what is news which we will achieve from this EBC meeting. So we can start, I think, with the first yes, that is Jacek Legutko. So is it better angio or intracoronary imaging guiding procedure?
It seems to be the easy job for me after the previous sessions and previous discussions to convince you that intravascular imaging is indispensable for achieving optimal result of bifurcation treatment. But it is never easy if you need to debate with Yves Louvard, who is the master of research and education in bifurcation treatment. So I will start with simple things and the rules which were established how to treat bifurcations within the European Bifurcation Club. Keep it simple, understand and the original bifurcation anatomy, optimize function and flow, and to limit the number of stents. And it's easy, we know that, but if we go for the reality and when we use only angiography, it is quite difficult to appropriately assess the vessel dimension, to assess the stent size, balloon size, as well as to know about the plaque distribution and morphology. And of course, if we use intravascular imaging, it becomes much more easy. We can appropriately assess all those parameters which are necessary to perform so-called optimal angioplasty. And we can do it both by intravascular ultrasound and by OCT. And it was presented during this meeting in different lectures. What is very important for me is the underestimation of calcifications by angiography. We have discussed how it is possible that we achieve optimal results so early, in so low number of patients. I mean, stent expansion in angio guidance in Illumin 4, it was 25%, in OCT guidance 40%. Even with intravascular imaging, we probably underestimate, and we need to be much more careful in this, and we should be much more careful in appropriate lesion preparation before stenting, and I believe intravascular imaging is exceptionally helpful for this particular reason. However, what is most important afterwards is to check for optimal result of stenting. Angiography very often is not enough to assess this stent expansion. Of course, you can use stent enhancement systems, but I believe that what you really need, especially for complex cases, is intravascular imaging, because it will tell you not only about stent expansion, but also about what happens at stent edges. The most important reasons for stent thrombosis are undiagnosed dissections, not covered plaques. We can see also with intravascular imaging protrusions. We can see stent malappositions. And we can also diagnose what is very often missed by angiography only, so-called stent deformations. When they happen, of course, they increase the risk of MACE, and in fact, especially in left main, the presence of stent deformation is one of the major predictors of MACE at follow-up. So we all know that, and it was discussed also during this meeting, but the most important are data. And of course, for left main, for many years, we have collected a lot of registry data, and the meta-analysis is showing us better survival after imaging-guided PCI in comparison to angio-guided PCI. We have less myocardial infarctions, less stent thrombosis, less revascularizations. Of course, there was a debate. Those are only registry data. This particular registry was not included in the meta-analysis. However, the results are absolutely the same from the British registry. We have again mortality benefit with the intravascular ultrasound optimization. And what is most important, because this we discussed many times during EBC and past editions, that of course experienced operators, they do good enough job without intravascular imaging. Here we see that the most advantage of intravascular imaging guidance for left main PCI was present in the lesions treated by most experienced operators, probably also the most difficult lesions. And nowadays, we have the randomized trials, which were really necessary to finally decide on what on use or not to use intravascular imaging. First, Renovate complex PCI trial dedicated to complex lesions, published at New England Journal of Medicine on April, and then dedicated trial to bifurcations, to complex bifurcations, October trial. Both of them were positive, so we can say now that we have randomized trials. And what is most important, and was also presented by Greg Stone, this network meta-analysis based on more than 10,000 patients, showing us that with intravascular imaging we can significantly lower the risk of cardiac death, all-cause mortality, more than 50% reduction of stent thrombosis, and also reduction of target lesion revascularization. It seems like there are no differences between OCT and IVUS. However, this is the next debate, so I will not touch it. Let me go for a while to another field, heart failure field. And as you are aware, 2 trials on the use of fluosin in heart failure with mildly reduced and preserved ejection fraction were published in New England Journal of Medicine 2021-2022. Both were positive according to the primary endpoint, which was death and rehospitalization due to worsening of the heart failure. In fact, there was no difference in death. Most of the benefit was related to the lower risk of rehospitalization due to worsening of the heart failure. And what happened next? It is amazing that the group of people concentrated on that topic decided to release just 2 years after the publication of the Heart Failure European Society of Cardiology guidance, the update. And it was really difficult even to enter the room in Amsterdam. Thousands of people were interested to see this document and to acknowledge this, that after publication of these 2 studies, both fluosins have now class 1 indication and should be used in all patients with heart failure with preserved ejection fraction and mildly reduced ejection fraction. Today, we are at European Bifurcation Club, and I believe that taking into account all the arguments, and especially the new research which was published this year on the topic of the use of intravascular imaging, we should really acknowledge that intracoronary imaging is indispensable for achieving an optimal immediate and long-term bifurcation PCI result, and we should really advocate for class 1 indication for the use of these devices. And please don't worry about the cost. The cost of the IVUS or OCT catheters nowadays is the same as the cost of only 1 year treatment with fluosin, which are prescribed for life to our patients. Thank you very much.
Okay. Please, if you have the more difficult part of this controversy.
Sorry, I need some put my glasses. Okay, so my talk is there. Yeah, so first, dear Chairwoman and Chairman, thank you very much for inviting me in this controversy. The title of my presentation is Intracoronary Imaging is not indispensable for achieving optimal bifurcation PCI result. After multiple publications on this topic, including 28 meta-analyses between 2007 and 2023, we are invited to see today 3 big randomized trials showing that intravascular PCI guidance is better than angio guidance and so justifies the cost of the product. Here we go to Element 4, a big trial published in New England Journal of Medicine. Element 4 is a very big trial comparing OCT guidance with local standard practice. Remember, angiography guidance. Here is the primary, so back. So it's black. I have to put the lumen? Yeah, okay, back. Yeah. So here is the primary, no, Element, it's here. Illumin is very, very big trial comparing, I said that already. So here is the primary endpoint, as you have seen, cardiac death, target vessel MI, and ischemia-driven TVR, showing no difference. The only primary endpoint, positive primary endpoint, is the difference in minimal stent area. And when you convert this area in diameter, this is 2.7 millimeter versus 2.6 millimeter. So OCT is not better than angiographic guidance. Is IVUS guidance providing superiority? Because this is the reference imaging, intravascular imaging over OCT guidance. We have also a big trial, Octivus, to compare OCT PCI guidance versus the IVUS reference. 1,000 patients in each group. A follow-up at 1 year, and as it is a non-inferiority OCT trial, here are the results. Yeah, sorry. Oh, here is the result, which is absolutely showing that OCT is non-inferior to IVUS. So maybe the failure of showing something positive is related to the fact that most of the lesions were not bifurcation lesions. So if we look at a specific bifurcation lesion, maybe different, because this is more complex. Why is it more complex? Because there are 3 diameters. October trial is October trial is a dedicated trial to coronary bifurcation lesions. A big trial, again, 1,200 patients, 600 in each group, and comparing OCT guidance and angio standard guiding. Remember standard guiding. And the result, no difference. And no difference. There is a clear advantage of OCT guidance in terms of usual primary endpoint at 2 years. What is the standard of care? What is the standard of care? They said standard of care of OCT guidance in terms of What is the standard of care for bifurcation stenting if you don't have intravascular imaging? Can you stop the automatic slide, please? So on the left, you have this Opus trial. On the left, you have a phantom on the left with a defined lumen area. Then you have the same phantom measured by OCT, which is exactly the same area as in the phantom. IVUS is oversizing. On the right, this is diameters. Well, you can see that IVUS is oversizing the result of OCT, which is the reference, by 9%. Stop it, please. Go back. 9% of the sizing, and angio is 5% undersizing. It's easy to understand and to remember that if you measure with a dedicated QCA, you add 5% and you have the diameter. Then we are going to, this is the work of my associate, Thomas Ovas, published in 2013. He's telling us that when you are expanding your stent, and at 14 atmosphere, there is a difference between 5 seconds versus 25 seconds. And the difference is 0.2 millimeter. 0.2 millimeters, stop it, please. 0.2 millimeters is 200 micron. 200 micron is malapposition, yes? So you can avoid that. Second point, the balloons are elastic. This is ideal to deploy a stent at the diameter you wish. So this is the curve provided by a company. First inflation, you saw that the diameter is under the provided curve. Second inflation, this is overlapping the provided curve. And a third inflation, you have oversizing of the balloon regarding the provided curve. So it means that in Massy, since that times, we are always inflating 30 seconds and at least 2 times 30 seconds. Easy to remember. And when you look at this, I have to change my place. Knowing this, you can select your balloon for QCA from QCA using the 5% supplement. In case of diffusely diseased segment, like here in the left main in the middle, you can use a formula that was given us by Gérard Finet. You can calculate the true diameter of the diffuse disease in the left main. This is also easy to perform. Sorry. That now stent enhancement, especially with injection, is helping you to oppose the stent. And it is said by Akiko Maehara and Gary Mintz that there is a very good correlation with IVUS. So we have an IVUS. And finally, you have seen this morning, pot puff. So you inflate a balloon in the position of the pot, and you look if you have some contrast is going on. It is on the right. On the right, you see that the contrast is not going on. So this is blocked. Not on the right, sorry. Is blocked. So when you inflate your balloon, you have no contrast crossing, you are well opposed. You can use also this technique when you deploy a stent as a crossover. You block the distal bed, and you see very well the contrast going to the side branch. You see the position of the carena. You see the risk of a closure with the carena shift. So, were these tips and tricks recommended in the angio arm of Illumen 4? I remember that the cause of absence of difference in Illumen 4 was related to the COVID. The operators were not taught properly for the treatment, but it was the same for the angiographic guidance, you know. So what is the recommendation for OCT and angiographic guidance? OCT a lot, angiographic guidance not a word in a supplement, not a word. If you look in October, you have the description of the steps of OCT guidance, not a word about guidance with QCA. So for me, October is not a fair comparison between angio and imaging guidance. You have to redo it. Thank you very much. Sorry. I'm sorry. I forgot what Francesco sent me. He sent me something very interesting. It's another trial coming from Korea again. It was in a small room in Amsterdam. So the hypothesis is visual guided PCI remain largely unchanged over 40 years, despite many limitations. We hypothesize that the QCA guided strategy with incorporation of lessons learned from IVUS, I would say OCT, I would say simulation, I would say bench, may help to optimize the stent deployment and offset the benefits of IVUS guidance. Here are the receipts for QCA guidance for IVUS guidance. At the top right, you see the correction of the QCA diameter measured. It's not a dedicated QCA. Dedicated QCA solved the problem. And in this trial, bigger than October, there is no difference. It's the same endpoint. And you will say, this is not a bifurcation study. No, there is only 2/3 of bifurcation and 50% of left main. So remembering lessons learned from bench, QCA, IVUS, OCT, and simulation, intracoronary imaging is not indispensable for achieving optimal bifurcation PCI result. Thank you.
Thank you, Jacek. Thank you, Yves. So I have two questions. One is to who, and the second one is whom. So there is a lot of problem how to read the results with OCT. So according to first question, who is the expert who should read the OCT and after how many procedures? And the second one, to whom? So which means, should we use this IVUS or OCT to every kind of bifurcation lesions, or to complex lesions, or to left main, or to some LAD diagonal branch? Which kind of lesion is really target for the OCT or IVUS? So let's discuss.
So, may I answer that? I think the way to improve the deployment of the stent, they are known since a long time. Gerard Finet formulas, we know since the beginning of the meeting. The plastic nature, not only elastic, but plastic nature of the balloon, which is increasing in diameter at each inflation, is known since for 5 years, maybe more. And stent enhancement, especially with injection, is known also. And the pot puff is certainly new, and it can be used not only in the pot, but also for crossover stenting. You know that the distal main segment is occluded, and you look at what is occurring in the side branch. So you can manage the inflation of your stent. You know, it's easy and very quick, and it's very easy to perform. So I think with this, and the QCA, modification of QCA, we know that QCA is giving a diameter which is reduced, and we have some explanation for that. It's a bit complex, so I won't spend time on this. Of course, it is better with dedicated QCA, because dedicated QCA is giving the true diameter immediately proximal to the side branch, and the true diameter immediately after the side branch, distal to the side branch. If you do the regularly tapering vessel model, then the diameter proximal to the side branch is reduced, the diameter distal to the side branch is increased artificially. This is not the good one. You have to know that this has been repeated and repeated and repeated in this meeting.
Maybe I can give the direct answer to your question. For me, definitely all left main PCI procedures should be done with intravascular imaging guidance. There are no doubts about it. And my other indications are also complex bifurcations, especially in calcified lesions and especially in patients at high bleeding risk that I need to achieve really optimal result. And I believe that this discussion is really important because I didn't touch, within 7 minutes, it's not possible to tell everything what you want to do. But the most important problem which we face in interventional cardiology is that especially in patients with chronic coronary syndromes, all the trials were not positive for interventional cardiology. Those dedicated to heart failure, patients with heart failure, we have ischemia results, and we have ongoing debate to do revascularization or not. And I am really sure that if we want to convince people and really help our patients, except of treating their symptoms, but just to improve their outcomes, we have to do optimal procedures. So it means that if we have so many data, if we have this meta-analysis showing us that with intravascular imaging, we can improve survival, we can improve lower the risk of stent thrombosis, lower the risk of TVR, we should use it more liberally. If we use it 10-20%, then it means that on country level, like in Poland, we have full reimbursement for intravascular imaging for the last 6 days, and on country level, still it is 5% of the penetration. Of course, there are centers doing it with 30-50%. The same happened like 15 years ago with radial approach. First centers were using and they were convinced, and all other centers, they were using only a limited number of cases because they trusted in femoral approach. Then the data came on mortality benefit and we switched. We use in the CAD lab those methods which we use routinely. If intravascular imaging is not a routine, it would never be used in more than 5-10% of cases. This is my answer.
Okay.
Some
comment from the.
I have another one. This is the last and this is the worst. I'm very sorry. I'm very sorry, but you know, you remember in syntax, we are speaking about syntax. Yeah. In syntax, in the world, there was one country with a non-inferiority to surgery, and it was France. This is the only country where we were non-inferior. And it probably was related to the quality, not only the quality of our surgeon with a very high rate of arterial revascularization, but also by the fact that we were understanding the tree diameters and preparing the treatment with tree diameters. And now in our group, sometimes some IVUS were performed, and it was recommended for the beginners, the newcomers in our group. But after that, we learn the lessons, and we don't need any more.
Let me remind you that in the Syntax trial, the penetration of intravascular ultrasound was only 5%. And we took it into account, and Professor Sirois established the Syntax 2 trial with 85% penetration of intravascular imaging. And as you know, the risk of MACE was more than 50% lower, and the mortality was close to 40% lower in the publication. Of course, it was not the direct comparison, but it is a strong signal that with intravascular imaging, we can really improve outcomes of our patients.
So if I like to comment that manual cars are doing very well, but automatic are better. And still manual can reach 130 kilometers, but automatic is the beauty of the IVUS that it gives you details, and so some cases, of course, you cannot generalize to every place. I come from a country that it's reimbursed, but only in limited cases. So like left main, you don't estimate the size. You need more details about that. But if it is going to make you to slow your pace, for example, in acute cases, you don't have IVUS immediately, and the case is acute, then you don't need to do it. We still do it, but of course, perfection is demanding.
May I answer to this? Yeah. But the amount of reimbursement. So, into the audience, if you don't have IVUS on OCT, are you following the rules? The rules have enumerated. Did you know these rules? Are you using them? Standard announcement with injection, correction of the QCA measurement, dedicated QCA if you have, that's okay. Several balloon inflation. Several balloon inflation. Not 5 seconds that we hear in many live cases. We see on, we hear on. And 5 seconds later, click, it's finished. This is the malapposition. 200 micron was shown on my slide. This is malapposition. If you inflate 3 times 30 seconds, your balloon and your stent are on the wall.
Well, one more comment maybe. We also were a part of October study and including 120 patients. And I can say we learned a lot, although we have quite experience with bifurcation starting with Nordic 1 from 2004. So, and yeah, and I think other point is also if you are doing quite a lot of imagings, it helps also you in case where you don't use imaging, you have better understanding and so.
Yeah,
so.
Of course.
Yeah.
Okay.
Well, I think the question is, does intravascular imaging help most interventionalists improve their outcomes in bifurcation lesions? The question is not, does it help every interventionalist improve outcomes? So I think we have to go for the majority, but I think the training is really important because the October trial had a lot of training in it, and perhaps it was the training that was really important because just putting an imaging probe in a vessel doesn't do anything. It has to lead to a result. So I think the training has to go along with the use of the intravascular imaging, and that's the important thing that we need to do.
That was my first question. Who should perform IVUS or OCT? After how many procedures?
Yves, I'll just ask you, I mean, I think that one advantage of OCT is especially looking at very eccentric calcification kind of hanging down from the roof of the vessel wall, which I don't really appreciate from the angio, but I do appreciate that from OCT. What do you do in those cases when you just...
Are you doing 100% of OCT?
It's not a lot. I agree with
not. So
your point
please answer
well
me.
taken.
Please answer me. So you use QCA, or if you use angio, Maybe you use angio without using QCA. If you use QCA, do you make a correction? Have you a dedicated QCA? Yes or no?
No.
No. So you make a mistake.
Yeah.
You have to correct.
Your points are well
You have to
taken.
correct. Normally you have stent enhancement. Normally you have stent enhancement. For sure you have stent enhancement on your machine.
Yes.
Yeah.
But
Injected
but-
stent enhancement.
but I don't-
You see the wall, you see the struts.
Correct. But I don't, when
And
I
the
have
pot puff,
very,
you know the pot puff?
when I don't have, when I have very eccentric calcification, I can get stent apposition at the calcium, but not at the side, at the shoulders of the calcium. That I do not get. And I can only see that with OCT. I understand it's not a lot of patients.
To all of you who don't have intravascular imaging, please use the simple rules. There will be on the site of the EBC soon.
One
We
short
have to
comment
go.
about pot puff technique, because it was described many years ago during
Yeah.
live cases as a IVUS for poor people.
Ah. So we are poor people in France, we are not people.
Thanks. May I see the result of the poll? So, if no. You obtain an if you obtain an acceptable result.
This is
40%.
significant.
Okay.
So if not if, it would be 90-10.
Okay. We have to move for the next controversy. Is OCT versus IVUS. Is the new gold standard for bifurcation intervention. The first speaker is Peter. Peter, whenever you want.
Thank you very much. And I think Yves did pretty well, actually. That's pretty impressive. So can I get my slides up? Great pleasure to be here, friends, ladies, gentlemen, chair, and panel. I think it's 1-0. It's always good to go in at half-time 1-0 up. We like to win these things. I've always lose debates, so I think I'm going to win this one. And I'm a simple guy. Okay, I'm not going to give you a whole data tranche. I want to just tell you why I think OCT is really good and what it brings to the table, literally to the table. In my center, we have access to all imaging devices across a range of different vendors. They all bring things which are unique to bifurcation PCI, and I think they can all have a role. But we've been discussing this all weekend, and I think the sessions have been really fascinating, and you've heard from a variety of different speakers. And in my opinion, it's fairly clear that in 2023, OCT is the really choice imaging catheter we should be using for bifurcation. So that's what I want to tell you. I'm going to share that with you, and we're going to beat IVUS in this particular case. Okay, just today. So when we do imaging for our bifurcations, we're looking obviously to get very accurate measurements. You can use QCA, but I think imaging is better. Lesion preparation, that's key to any success in all PCI, and you get it much better from imaging and better from OCT, as I'm going to tell you. Measuring the pot, making sure there's no abluminal wiring, checking where you're crossing, these are crucial things, making sure there's no carnage at the end of the case, and getting numbers at the end of the case that prove you've done a good job. So if we take the first one, or the first three, so this is a recorded case, very fast for you, but just shows the workflow. Co-registration, massive advantage. This is apt to view, it's old software now, but it's simple to use. This is really easy. This was a calcific LAD lesion involving a bifurcation with a diagonal. A lot of it calcification, as you can see. You can't see this on the angiogram, not so clearly. We've already done orbital atherectomy in this case, so it's required a bit of modification. But you see, simple workflow, all done with a handheld control at the side of the table. It is speeded up, but it still takes just a few minutes. Fractures there, calcification still present. Move on to IVL for this case, because that's what we would do in this sort of situation where we've got deep, thick calcium. You can't see it on an angiogram, and I don't think IVUS is as good. What about where you've crossed? Can you see that on angiogram? Definitely not, but on IVUS, no, not as good. Here we've got a proximal cross in a provisional case. We don't want to do a balloon or kiss there. It will damage the stent, and maybe that's why the trials of kissing without imaging are going to be neutral. What about the mistakes that can happen during PCI? We all make the mistakes. But you can see very clearly with the enhanced software, if you've cleared, the pot's very good, but sometimes you need to kiss and you get a really nice side branch appearance. You can see it all with OCT. You won't see it so well with IVUS. And what about this? When you've put the stent in and you've optimized, here's back to that same case. There's the stent. Within seconds, you can see it. The stent expansion's great. It's about 80%. It's good enough, particularly with calcium. We can measure the distal dissection. We can look at the proximal edge. It's all very clean. We've landed in very healthy tissue. This stent's going to last a long time. It's done well. We can focus on the bifurcation, as you're going to see in a second. We can toggle up and down. It's really nice workflow. We can see where the bifurcation is. We can see what the ostium looks like. We can decide whether it requires any more modification, any modulation. We can look at this, the 2D images, moving back and forth. And you can see I've got Helen with me, helping me. This is she's doing the case. And together we look at this and both say, this doesn't need any work. It's fine. Great job. Leave it alone. And that's really insightful. So let me take you on this journey. This is a more complex case. This is the left main bifurcation. Now, provisional, I use a lot, but in this case, I think we've got some criteria here for a 2-stent bifurcation strategy, and I think from definition criteria, it meets probably DK crush is reasonable. So upfront atherectomy, because there's clearly angiographic calcium, it's too tight for an imaging catheter. So we perform that first, and then we use some kissing balloons just to create some space, and then we can adjust. Now, this patient gets randomized in October, as Niels and Eval have shown you, great result. So this was a simple thing from October. What's going on with the first runs? What about your lesion preparation? What about the vessel? Get some measurements, work out where you're going to be landing your devices. You get all that information. But have we done enough with atherectomy? No. There's still loads of calcium. It's deep, not modified enough for a 2-stent. We've got to go and do some more. Pick any algorithm you like. This is one that's published, ICR3. We go back with Shockwave. That creates a really good expansion. We go back then with our OCT as per protocol. We check it's adequately prepared. We're ready now to think about stenting. A lot of work's gone in, a lot of runs, but we know what we're doing. Stent to the circumflex. In our normal crush technique, we're going to crush that out the way with our balloon. After we make sure it's properly expanded, we may have to go back and do that. And then this is a crucial step in the DK crush, as you know, the pot, because if you don't properly crush it, you're going to wire back in the ablumen in a different spot to where you want to be. Dual lumen catheters, we use these extensively throughout October, even in the angiographic arm, because we didn't want to, as the next phase was to make sure we knew where the wires were. So that was tricky, and as Niels has shown, it's not always so straightforward in real practice, but we got better at doing it because they were teaching us as well. Then we're ready now, after our first kiss, to go in and put our main vessel stent in, choosing the right platform. Again, key steps, really important. Doesn't matter whether you image or not, but this is important stuff. And then you do another pot, of course, and then we have to go back. We have to rewire again with dual lumen, and then again using our OCT to check our wire position before we can go on and do our final stage kiss. So quite a lot of steps, a lot of OCT runs, catheters getting a bit fatigued. But now we're at the point now where we think we've finished. We can do this is the third step to really understand, have we got really nice result. We've done LAD, we've done circumflex, all looks very good, nice expansion, nice carina. I think we're pretty happy. We're looking for any kind of damage, any longitudinal stent deformation. There you go. For 4 key things, these have all been mentioned today. They're really important, and you get it all with OCT. Really straightforward. The data's there to support it. That's the final result. It improves outcome. Why aren't we using it? It's the key technique. Technical superiority, first-class unique data, and refinements to the technology that's going to make it better and easier to use for the majority of operators. All the information on one screen. Very, very simple. I like to travel, and I've got different ways of traveling. But when I'm here at EBC, I'm rooting only for one team today, of course. And I'm a pleasure to be here, and let's watch the rugby later and celebrate. OCT is going to win.
Cool.
Okay, so that it's very hard to say no following the Peter's elegant talk. Okay. So I think this question is very relevant to me because my personal usage of IVUS versus OCT in terms of intravascular imaging is IVUS 99%. So basically, I'm the IVUS person. But while preparing this talk, I'm thinking about what's the beauty of OCT over IVUS, and you know that in terms of luminal visualization, plaque vulnerability, short level resolution, clinical evidence, big, beautiful randomized trial. So I've almost converted to OCT while preparing this talk. But today's my duty is to defend the IVUS, so that the lectures one by one. So this same reason, OCT, IVUS, so you will easily recognize that OCT is better. So we should use OCT rather than IVUS. But the question is whether I need to convert to the OCT from IVUS. But personally, I feel that the IVUS can provide us enough beautiful information for bifurcation PCI, not only luminal narrowing, but it can provide us a very important element in terms of amount, character, and distribution of plaque. And this plaque information is more important for the bifurcation PCI because that the luminal narrowing mechanism is different between the non-bifurcation and bifurcation PCI. And for this side branch lesions, two lesions, one is plaque, mainly plaque plus positive remodeling, and the other is small plaque plus negative remodeling. Of course, the specialist can recognize the vessel, but it's not a usual one. And for this case, can you click this video? Okay, may not working, but this illustrates this is pure negative remodeling case. Of course, that this can be also recognized by the OCT, so that in terms of lumen visualization, OCT may be better, but I can defend IVUS while saying that the IVUS can also provide enough information, at least to me, and even better in terms of the plaque characteristics and plaque quantity. And OCT is very famous for its discrimination ability for TIFA or plaque vulnerability, so that again, the same cross-section OCT IVUS, you see that the beautiful images of OCT, cap thickness, and lipid arc, so that you can discriminate TIFA or not. But again, we have to understand the importance of plaque itself as a vulnerable feature. You know that Prospect 2 trial, in both trial, not only the lipid amount, but the plaque amount was the key element for the plaque vulnerability or patient event. So that I don't want to bother you with this complicated slides, but the one thing I'd like to mention is this is the features we've analyzed in terms of plaque vulnerability while combining all the quantity and quality metrics, and we found that the quantity metric is more important in terms of plaque vulnerability assessment, so that the plaque quantity really matters. So for plaque vulnerability, OCT may be better to define TIFA, but while plaque burden, which can be better assessed by the IVUS, can be at least non-inferior vulnerability feature. The other thing that cannot be beaten by IVUS is that the strut level OCT-guided bifurcation PCI. So we've seen beautiful images from Peter and our Japanese colleagues, so this cannot be done by the IVUS. But I'd like to raise this question that those struts really matter in terms of clinical outcome. So I really have this question several years ago, and that's the reason why with this simulation model. So in this slide, as you can see in the right side, we made two models. One is strut obstructing the ostium of side branch. The other is a perfect side branch angioplasty while leaving no struts there. So we worried about that low osseous area, but we know that the FFR flow reduction, that strut does not make a big matter. But it is interesting to see that when we calculate the percent area of low osseous stress, there was no difference while having some struts there and having those struts there, because that this osseous stress, low osseous area and flow disturbance is mainly determined in the main vessel area, not the osteostrut area. And this was also assessed by the other studies. And as you can see here, side branch contribution on the total lower structure area is very minor, so that strut doesn't matter in terms of clinical outcome. And that's the reason why in this very large sample size 5-year follow-up, even though this is not a randomized study, side branch opening was not translated into the clinical benefit in terms of leave it alone strategy. And finally, evidence. We have a beautiful October big randomized trial, but we also have a great number of meta-analysis results, even though this is not specific for the bifurcation and also the no randomized trial, but the decent number, more than 6,000 and around 5,000 meta-analysis results. And we also have almost 10-year follow-up results. So when we think about all these metrics, I should say that I have to convert it to the OCT because OCT is better in terms of all these elements. But when we think a little bit more, my answer is still no, even without talking about contrast. Thank you very much for your kind attention.
All right. Thank you very much, both of you. So I'm a real OCT girl. So I perform OCT a lot. I'm better with that than with the IVUS, and I go sleep better after some procedure when I perform OCT. But I still have some confusion about it. Even in this great randomized trial, only in 20 to 80% the great target, the main target were achieved. So do we need another measure which will be gold standard to achieve in this OCT procedure or not? This is a question for Dr. O'Kane.
Sorry, could you just give me a summary of your...
Do we need another measure to achieve in this OCT procedure? Because in this study, it was achieved in 50%.
Yeah,
in some another 20 to 80. So what is good? What is great? What is good enough?
Yeah, I think, I mean, the challenge in doing randomized trials with any device is the operator experience and operator skill set. And I think this is why we see such variance in the results of all trials. And I mean, the team who put October together, I think, did an incredible job to actually get everyone trained and give constant feedback to make us better at doing what we were doing. But despite that, there was still a lot of protocol non-adherence, particularly in the two-stent group. And I think that's a consequence also of the hardware. The OCT catheter often kind of gives up after about 4 or 5 runs. And some of these cases, you had to do many runs. So I do think that we probably be nice to try and streamline and perhaps there'll be more insights into how we can do this in a more, less runs, more systematic. What are the key features of the technique with the imaging that gives us the benefit? And I don't think we know that from the results, but we may find out.
A question for both. Do you think that the left main or not left main bifurcation can change the technique to evaluate the bifurcation, OCT or IVUS, or IVUS and OCT is for both?
So for generally, we know that for osteo left main, it's difficult to be assessed by the OCT, but we also know that the OCT specialists can do beautiful work with the left main procedure with OCT, so that I think that except for left main osteo lesion, but there's no big difference between IVUS and OCT in terms of feasibility.
Yeah, I agree. I mean, I think the ostium is still, it's still work in progress for OCT in the sense that you may get away with it sometimes, but you may not see that very proximal strut, which you could have deformed. Obviously, the core lab has all that information. So, I think IVUS is probably easier for those osteal lesions.
Just a small point. Preparing the meeting, I have seen a paper by Patrick Saristin where there was a mixed catheter, IVUS and OCT. Maybe it will be a good solution for you.
So my question. Okay, my question to Bon. So you said you are IVUS fan for a long time. So now there have been advance in IVUS itself. It is not like 10 years ago and 5 years ago. So what before and what now is the percentage that you did IVUS and still you need to do OCT. And the other thing, for Peter, do you think that having 5 modalities that may also make you confused, or you have a standard that you do the routine work, you better rely on 1 or 2? So this is my question.
Yeah, so I agree that the IVUS has been stationary for several decades, but now it's evolving. Maybe it's stressed by the OCT appearance, but we have a high definition, 60 megahertz, and the fast pullback, and maybe it will facilitate the automation and co-registration, so that that will be helpful a lot for the IVUS lovers.
I have a question. Now there is a consensus statement by European Bifurcation Club and CTO. So there probably intravascular ultrasound in a CTO setting. How do you do an OCT?
No, you can't. I also have a question for both of you. When you look at a lot of the American trials, it's and also the American meta-analysis is done with operators that don't have that much experience. The average number of PCIs for American operators is 40 PCIs a year. Now, not all do like in South Korea, where you do hundreds of PCIs a year, and in Europe but even in Germany, many PCI operators, they don't do that many PCIs. So what would you recommend using OCT or IVUS if you don't do that many procedures a year?
So I'll try and get all those questions in. So having a lot of equipment in your lab, I think, is quite useful. For me, I find it helpful because every bit of equipment has strengths and weaknesses, and I think certain cases you really want that information, i.e. things like co-registration. Sometimes very nice to have it. Some of the IVUS systems don't have it. Some IVUS systems are super quick in the middle of the night during a STEMI. You can get it out, super done, get the information. You may only want just a vessel diameter or simple things. So I think that's how you can niche it. Then going up to your question about sort of how do you train, who do you train? I think the next generation, I think the equipment's going to be so good, like with Ultron 2.0. When you get all the information on one screen, people are going to go for that because it's like having an iPhone 15. It's just so quick and easy. You're never going to go back. Once you've seen it, and that's how you're going to learn how to do PCI. It's going to change the game. And then to your question about CTO, for me, CTO, IVUS, because I don't want to inject loads of contrast. But you could do OCT, but I think IVUS is what I'd use in CTO. But luckily, this is a bifurcation, so we're okay.
Yeah.
Oh, okay, but you're making it hard now. No, I think I think you could use either, but I think IVUS I'd probably go for, to be honest.
Yeah. No, I agree with Dr. Dougal that in bifurcation with CTO, the injection may induce more dissection. So IVUS is completely more useful. No, in this context, I think the advantage of IVUS is clear. Do you think so?
Yeah. So that the Octavus, they have to exclude the renal failure patients, but I think it also depends on the level of experience, so that the OCT specialists, they understand how to manage the contrast amount, but the general user, I think it really matters. But I agree that in case of huge dissection, contrast injection may cause aggravation of dissection flap.
Yeah, but in general, in CTO, the number of injection is reduced because the jet can increase the dissection induced by the wire, by the wire, and by everything. No? Okay. Any other comments? So we can see the vote. Yes. The winner is Peter. Okay, so we can conclude, no?
So we can conclude at the end. Thank you very much, all of you. So I think the winner is OCT, but I really think that we need another measure, and then we need a concrete measure in the terms of a very point of bifurcation lesion in the terms of carina, on the terms of side branch, which is a real position, apposition, and where is the what is real good scaffolding. So I think that we are looking for that result. So thank you very much again.